So thank you very much for the invitation, and also thank you very much to Bayer Pharmaceuticals and the Kerala Ophthalmology Society for allowing me to come here. This has been thus far a very nice trip through India. This is my third stop, actually, third of six in terms of working my way around India. We're working right now on getting the remote. Let me know when I can jump into this and when you want me to hold on. Okay, good. Thank you. So we do have, I believe it's 4 remote sites, and obviously we want everybody to be able to remote in as they've attended sites outside of Kochi proper. So here are my disclosures, and no surprise that my disclosures also indicate that I do have a relationship with both Bayer Pharmaceuticals and Regeneron, who of course is the inventor and developer of aflibercept.
I'm so sorry.
Okay. The discussion on diabetes, I think, was very pertinent. India certainly is undergoing a internal revolution because of modernization, westernization of diet. And that's why you're going to be seeing, even though incidence or the prevalence of diabetes and diabetic retinopathy is relatively low in the population, you're experiencing a significant increase. In the United States, we think that we have very high levels. The prevalence of diabetes is about 11% in the US population, but we are much lower than the countries with the highest levels, and those are the ones in the Persian Gulf. Qatar, according to the last data I saw, had the highest percentage of the population with diabetes, and that was approximately 30%. When I go to Riyadh and talk there, as many of these talks, we talk about macular degeneration and diabetes on equal footing, or we skew the talk more towards macular degeneration. In Riyadh, they tell me that in their injection clinics, 95% of their injections are for diabetic macular edema. So parts of the world, of course, have different disease prevalences, and you here are going to experience a significant increase in diabetic patients as diet and prosperity hits India. Also, you'll be facing the challenges of the diabetic macular edema increasing as time goes by. So again, getting back to this, here are my disclosures. Again, I have a relationship with both Bayer and Regeneron. This is a fairly broad-reaching talk. We go through several different topics. We're going to start with fluid and talk about what fluid means, what fluid is important with respect to the treatment of age-related macular degeneration, and which fluid we can ignore to some extent. And we have a lot of data that suggests that it's not just a matter of is there fluid, but where is the fluid? We have both prospective and post hoc analysis data that says not all fluid is the same. And so when we look at patients and evaluate their OCTs and their response to therapy, our own internal analysis should be not just is there fluid, but where is it? Because the story is much more nuanced than fluid, yes or no, but the reality is where is the fluid and what is the contribution? So when we talk about fluid, we really break it down into 3 different compartments within the retina: intraretinal fluid, subretinal fluid, and sub-RPE fluid. And we know now from several years of analysis, especially a lot of large studies with post hoc analyses, that intraretinal fluid is adverse to a good visual outcome. It is correlated with poor vision at baseline, with lesser increase in visual acuity with treatment, and with poor visual outcomes in the final analysis. Subretinal fluid, on the other hand, is quite the opposite. Subretinal fluid is associated with better visual acuity at baseline, greater improvements in visual acuity, and a better post-op post-treatment visual acuity as we measure that over time. And finally, sub-RPE fluid seems to be neutral. In and of itself, an RPE detachment in the presence of macular degeneration doesn't seem to make a big difference of visual acuity, either better or less than average. But if it's associated with subretinal or intraretinal fluid, then we think there is a correlation with sub-RPE fluid being somewhat adverse to visual outcomes. So most of what we're going to talk about is the subretinal as well as the intraretinal fluid, because those are the ones that we look at with respect to treatment response and try to analyze and determine how are we going to treat these patients. Are we going to be aggressive? Are we going to tolerate fluid? Are we going to change frequencies? Or are we even going to change drugs? We do have some prospective data with respect to subretinal fluid. The fluid study out of Australia took patients with age-related macular degeneration and with subretinal fluid, and at baseline randomized them to getting either aggressive monthly anti-VEGF therapy or tolerating the subretinal fluid as long as it was less than 200 microns. Now, I never measure subretinal fluid. To me, 200 microns is a lot because that's almost the thickness of the retina, but that's what they used in their analysis. And when they did the final analysis outcomes, they found that whether you measure visual acuity changes at 12 or 24 months, or whether you measure the proportion of patients with 15-letter gainers, it was pretty much exactly the same in those groups that tolerated subretinal fluid versus those groups that treated it very aggressively by giving more injections. So as you can imagine, the group that was tolerated ended up with fewer injections over time. But ultimately, the end result with visual acuity was exactly the same with respect to the subretinal fluid tolerance. And we have a lot of other data that also suggests this is a recurrent theme in the treatment of macular degeneration. The ARIES trial, you see on the right-hand side of the slide, tolerated up to 50 microns of subretinal fluid, which is more of a number that I can actually handle. Once again, I don't measure it, but I can eyeball it and think that's about a quarter of the depth of the retina. And in patients with less than 50 microns of fluid, they actually extended patients as long as the visual acuity was fairly stable. Altair, on the other hand, tolerated subretinal fluid in the sense that they allowed patients to maintain the same treatment frequency, but they didn't require more treatment as long as the subretinal fluid was less than 100 microns. So both of these trials tolerated. ARIES actually allowed for extension. And when you look at the data at the end of 2 years in Altair and ARIES, the results seem to suggest that the tolerance of fluid did not make a difference in terms of the final outcome. Harbor was a phase 3B trial from Genentech. And what they did was they took their Genentech, the standard dose of ranibizumab, the 0.5 milligram dose, and they were developing a superdose. The superdose was 2 milligrams. And they were trying to determine, is the superdose better than the standard dose? And so they evaluated it in four cohorts, monthly injections of either drug or PRN injections of either drug, and then they looked at the final analysis. Surprisingly, the 0.5 milligram drug actually did a little better than the 2 milligram drug over time. But what you see here is a post-hoc analysis from Harbor trial, where they looked at the presence of intraretinal fluid on the left, subretinal fluid on the right, and determined what were the changes in visual acuity at 12 and 24 months. And on the left, those eyes that had intraretinal fluid had than average improvements in visual acuity compared to those who had no fluid. On the right, you see that those patients that had subretinal fluid had better visual acuity than those patients that didn't. So it almost seemed to indicate that subretinal fluid enabled patients to see better or to improve better than those patients who did not. The VIEW trials also did a post-hoc sub-analysis that looked at the presence of intraretinal fluid in the center of the slide. Intraretinal fluid was correlated with visual improvements, and they looked at subretinal fluid on the right-hand side of the slide, and you can see that subretinal fluid did not make a difference. Whether it was present or absent, patients with subretinal fluid did the same in terms of visual acuity improvements compared to those patients who didn't. And in the post-hoc analysis, you can see that's broken down over time, where the intraretinal patients with dry intraretinal spaces had better vision over time. The patients who had wet subretinal spaces had better visual acuity over time. So the CAT trial looked at the same in a post-hoc analysis and found the same thing. Over time, the presence of intraretinal fluid is adversely related to visual acuity improvements. The presence of subretinal fluid is actually seems to potentiate the improvement of subretinal fluid. So all of this suggests that when we're looking at our patients, we need to break it down on OCT and look at the presence of fluid within the retina and beneath the retina and use those as our guidelines to treat the patients. Not just is there fluid, but where is the fluid and should we tolerate it or should we try to treat it as aggressively as possible? We talked about brolucizumab, and in the United States, we generally don't use this drug. I know in India, it's used considerably more than what we do. One of the reasons for using it, it's a very, very potent drying agent. It works really well. When you look at visual acuity outcomes of brolucizumab versus aflibercept, the visual acuity over the course of 2 years is exactly the same, despite the fact that brolucizumab dries the retina better. Why is that? Well, we'll go back to that in a couple of slides and show exactly why better drying does not correlate with better visual acuity. So several of us did a meta-analysis and literature review to look at the presence of intra and subretinal fluid from large studies and determine, is there a pattern with respect to visual acuity? So we first of all looked at studies that reported the presence of intraretinal fluid at every visit, as well as the visual acuity, at least through 1 year. And we found that for every study that we found that reported intraretinal fluid through 1 year, in every study, intraretinal fluid was negatively correlated with visual acuity. When we looked at subretinal fluid, we found a very different story. With subretinal fluid, the studies were equally divided between the subretinal fluid not really making a difference, either positive or negative with respect to vision, while associated with a positive effect on visual acuity. When we did that at 2 years or longer, we found the same thing. Fewer trials, but every study we saw with subretinal fluid was negatively correlated with vision, and the ones with subretinal fluid were split 50-50 between being positive with respect to subretinal fluid, or the visual results being of no particular difference. So again, we have a lot of post hoc analyses, and we now have meta-analysis, which is our best predictor of determination that we can get from the literature, suggesting there's a difference in the presence of fluid and where it is. So we go back to Hawk and Harrier, and I said before that brolucizumab dries very well, and it dries better than any other drug we have, but it doesn't affect the vision better. Why is that? When you look at the breakdown of the intra versus subretinal fluid on the top line, you can see that on the left, we're looking at subretinal fluid, and aflibercept in blue, patients with aflibercept actually had more subretinal fluid at every time point through the trials. But when you look at intraretinal fluid, which is the fluid that really matters, the intraretinal fluid was exactly the same in brolucizumab versus aflibercept. So the two drugs dried intraretinal fluid exactly the same. Brolucizumab had a difference because it dried subretinal fluid better, but that doesn't matter, because that's not what ultimately drives visual acuity outcomes. In fact, some people would believe that if you follow these patients long enough, it's those that have persistent mild subretinal fluid that actually have a lesser incidence of macular atrophy over time, because the subretinal fluid may serve to nourish the photoreceptors as well as the retinal pigment epithelium, hence protect against macular atrophy. So what about faricimab? Faricimab, of course, with just the bispecific, not only VEGF, but Ang2 binding. And when Genentech developed this drug, they first of all thought they may be able to get a superiority result, meaning faricimab will give you statistically better improvement in vision compared to ranibizumab or aflibercept. However, in their phase 2 trial, which is called the Avenue trial, they found out it really did not. It didn't really change the visual acuity results compared to standard monthly anti-VEGF therapy. So what they did was when they went to phase 3, they pivoted. And instead of trying to do superiority, they tried to do durability. And they looked at a extended mode of action trial, which was what Tenaya and Lucerne were. Now, there's a fair amount of talk that faricimab dries the retina better than does aflibercept. And when you look at subfield thickness slides here, and you look at the left-hand side of each of the lower graphs, you can see that the faricimab patients are actually drier. they have lower thickness relative to aflibercept. But as soon as you hit roughly week 16, and I've put those in boxes, and then you move from week 16 through week 48, the numbers are exactly the same. They crisscross. But the central subfield thickness, whether the patient was treated with aflibercept or whether they're treated with faricimab, are pretty much exactly the same in both of the trials. And so when faricimab is talked about as a drying agent, I think the data suggests it dries a little quicker, but it does not dry better after 16 weeks. And indeed, after 16 weeks, the drying effects are exactly the same. So how did that fluid guide the implementation of individualized treat and extend? Well, we break it down and look at subretinal fluid versus intraretinal fluid. The intraretinal fluid patients are those that we should be treating aggressively and try to get rid of it as much as we can. Now, there are times when, let's face it, we can give a patient all the anti-VEGF drug we want, and the intraretinal fluid never goes away. And in my hands, if I get patients out at 6 or 7 injections and the intraretinal fluid persists, I'm probably going to say, there's nothing I can do to get rid of it. And so I'm going to very slowly extend the patient because I think I've gotten the patient to do as well as possible. And there's no point in putting excessive anti-VEGF drug in there. But I'm going to treat to try to get rid of intraretinal fluid. I'm going to treat to tolerate improved subretinal fluid. So let me show you a couple of clinical cases. And these are some cases from my practice where we've had some good results, we've had some bad results, and we've had some surprising results, especially as it pertains to fluid. This first patient is a 75-year-old ex-US Marine, and he comes in with visual acuity now of 20/40 in this eye, and you can see there's sub-RPE fluid, subretinal fluid, and intraretinal fluid. So he has all 3 compartments. So what do I really want to do? Well, I certainly want to improve his vision. I want to get rid of the intraretinal fluid. I'd like improved. And if it's not stable, then dry subretinal fluid in the RPE, I'm not really worried too much about as long as it doesn't get worse. A worsening RPE detachment is a setup for an RPE tear, and those are eyes I really don't want to tolerate. So I started him on bevacizumab, and many of our patients in the United States begin bevacizumab, even to this day. Now, bevacizumab 3 times monthly, and you can see that 1, his visual acuity is getting worse. He's now 20/60. 2, the RPE detachment, when you look at the right-hand side of the slide, is getting worse as well. So now we have a poor result, worsening vision, increasing RPE detachment, at risk of an RPE tear, not responding to 3 monthly injections. And I think everybody would say this is probably a patient that deserves a switch because not only am I not getting a better result, I'm getting a worse result. So we'll switch this to aflibercept 2 milligrams. And after 3 monthly injections, you can see in the middle of the slide, he's completely dry. Not only did I get rid of the intra and the subretinal fluid, but I got rid of the RPE detachment. So I know I've got the disease under control. And at this point, it's fairly safe to say we can go ahead and extend the patient. We don't need to sit on monthly injections, and we can go ahead and increase the interval. And I slowly increased the interval. I'm fairly conservative, so I did it at 2-week intervals. And I got him up to about Q16, and I stopped at Q16, meaning I went along at Q16, he's doing well. So after about 3 years, I said to him, maybe we could consider stopping therapy because you're doing so well. You've had no recurrence of fluid. You're 16 weeks out. Let's give it a try. So I stopped the injections. And then while I was out of the clinic, he comes back complaining of decreasing vision in that same eye. And the CT on the lower left, it looks pretty good, except there is a little bit of fluid in the papillomacular bundle that wasn't there on previous examinations. And so he saw one of my partners, and the partner says, I'm going to treat you with brolucizumab. Patient returned 3 weeks later, sudden vision loss, hemorrhage, fluid, etc. We tried intravitreal TPA, face down positioning with a gas bubble, more brolucizumab, and eventually after a year, he ends up with a disciform scar and poor visual acuity, which was a surprise because generally brolucizumab, you would not expect to have an adverse outcome like this, but indeed that's what happened in this case. So we said, nothing much we can do with this eye. He's got a dry disciform scar. I'm not going to do anything. But 6 months later, he now complains of vision changes in the good eye, the remaining eye. And he comes in and looks like this. So you can see this multi-lobed pigment epithelial detachment, subretinal fluid, and I start him on aflibercept, and I'm going between 4 and 6 weeks, trying to get him as stable as I can. And finally, I get down to where you see in the bottom. This is after 9 months. And so I think at this point, I'm not going to get him better. But I'm going to say that I'm going to treat him probably every 6 weeks or more frequently because I don't want the disease to get out of control. And I don't want to put him in a position where he's going to get a catastrophic subretinal hemorrhage. So I'm going to treat him for the rest of his life because in an only eye with evidence of active disease, and to me, subretinal fluid indicates active disease, then I'm going to treat him for the rest of his life like that. So this is sort of an introduction to switching, because switching is a big topic that we all face now. If we go back 20 years ago, and I look at many of our panelists who are, if not as old as I am, certainly experienced for 20 years. 20 years ago, we had an interesting practice. Patients came in, we treated them with one drug, and that's what we did. And the only argument we had in our heads were how often do we need to treat them, but there was no such thing as switching. So now, as we look at our list of drugs, and of course, added to that are biosimilars, and we're going to get more drugs, we're going to get tyrosine kinase inhibitors, we're going to get more we're going to get more bispecifics, and we're going to get gene therapy. Our thought processes and analyses become much more complicated. So it begs the question of who should be switched and what are the results of switching. And so we have to really understand some of the challenges, and that is there's significant individual differences in how people respond. Just because patient A responds really well to a drug, patient B may not. And for reasons we don't understand. Maybe there's a different inflammatory component. Is the Ang2 make a difference? We don't really know. Is there something about the presence or absence of a vitreous detachment? There's several things that may come into play that are very difficult for us to predict, but we have to be aware of that. And because there's interpatient variability, we have to be able to switch therapies if they're not responding. We talk about primary response after loading doses. Generally speaking, 3 monthly doses is considered loading. I don't ascribe to that. I say loading is as many monthly doses as you need to get the disease under control. It might be 1, it might be 3, it might be 5. But whatever that is to get the disease under control, that's it. Dan Martin, who ran the CAT trial, in the PRN arms, how many were their loading doses? 1. And he contends to this day that for an anti-VEGF drug, 1 is the correct loading dose, unless you don't have the disease under control. So we talked about switching, we have to talk about disease response. And when you look at this slide, this is a really busy slide, and it's very difficult to get all the data on here. But what I want you to look at is the left-hand column. Basically, the authors here have talked about disease response as good, partial, poor, or non-response. And all I want you to take from this is there's a good response, there's a non-response, and then there's in between. And the other thing I think is important is to look at a couple of the factors up top. What constitutes a good response? Well, functionally, it's greater than 5 letters of vision improvement. And it's drying of 75% of your excess fluid. So that's easy to remember for a good response. What's a bad response? 5-letter vision loss, improvement in morphology. So if you can remember those things, then you got the good, you got the bad, and everything else is in between. And I think those are good things to be thinking about. The bad response people want to treat those very aggressively, either in terms of increasing their frequency or switching drugs. And so if they have no response, I'm going to switch therapy, change therapy, or in those cases that might be fibrotic scarring, we may actually discontinue therapy altogether. If you have a good response, morphologically and anatomically, of course, we're going to continue. And everything else in between is now up for debate as to do you switch, do you change intervals, how do you manage these patients? So let's talk about switching in the newer drugs, because anytime we have a new drug, the new drugs are always tested on what? Treatment-naive patients. So the new drugs are always used on treatment-naive patients as a starting therapy. But when we get them in our hands, how do we use them? We use them as switch therapy. That's generally what people do. That's not an unreasonable thing to do. No, that's not what the drugs were designed to do. And even when you look at aflibercept 8 milligrams, it was a treatment-naive drug used at starting therapy, although most people will originally start with switching. And because we think it's going to be available here probably in January, you are going to have to undergo that same thought process yourself. Do you want it as an initial treatment agent, or do you want it as a switching therapy initially, which of course is your decision to make. When you look at switching, we get a lot of mixed data. Here was a switching study out of Japan that looked at aflibercept 2 milligrams to faricimab, and you can see that 60% of the patients who were switched to faricimab ultimately discontinued therapy because it wasn't working well. 73% of those that were switched back to aflibercept. And that's an important concept of, if you're switching, be prepared to switch back, because sometimes you get a great response, sometimes you get a similar response, and sometimes you get a poor response. And the poor response is that inter-patient variability. Different patients respond differently to different drugs, and sometimes you need to go back. In this other trial by Kishi et al., they looked at trying to extend patients who were treated at weekly at intervals of less than 8 weeks, and they found that more than 70% of the patients could not be extended after switching from aflibercept to faricimab. So the switching, really, the majority of patients don't seem to benefit very much from a switching from aflibercept to faricimab, no matter what criteria used, for visual acuity, extendability. This was a comparative study, again, out of Japan, looking at patients who were initially treated, and the patients with aflibercept actually did better than faricimab in this trial. And finally, out of Great Britain, Bailey et al. Looked at switching patients with diabetic macular edema to faricimab, and they found that the visual acuity changes were very limited. When you scale on that graph, that's in letters. So it's, on average, patients gained fewer than 1 letter when they were switched from aflibercept to faricimab in patients with diabetic macular edema. And when you looked at the intervals really were not extended significantly. So the switching didn't seem to help the visual acuity, and it didn't seem to help the intervals when patients were switched from aflibercept to faricimab. So does that mean we shouldn't do it? Well, no, that's not what it means, and I'll go into that in just a moment. Last trial out of Moorfields in London, published this year. Patients began with aflibercept versus aflibercept 2 milligrams of diabetic macular edema, and their conclusion was the drugs work about the same. That they didn't see a significant difference when they randomized the patients to faricimab or aflibercept, and they treated them with patients with diabetic macular edema. So one more case before I can finish with the switching concept. This is a patient that came to me with diabetic macular edema, and you can see the morphology on the lower slide. On the left is the right eye. On the right-hand side of the slide is the left eye. 20/50, 20/70 visual acuity. I'm a very strong believer in diabetic, in the DRCR-NET Protocol T trial, because I think it was a great trial that compared the drugs. And so as a result, I always start with aflibercept in those eyes of 20/50 or worse. And so that's what I did here. I started with monthly injections of aflibercept 2 milligrams in both eyes. And you can see that over the course of 6 loading doses, she actually did quite well. And you can see that she's gotten down to the bottom of the slide here. She's 20/30 in one eye, 20/50 in the other eye. When you look at the morphology, you say, well, that's pretty good. It's not perfect. There's a little bit of intraretinal edema in the left eye, and there's a little bit more thickening in the right eye. So not bad, but a good response and a good visual acuity improvement. Now, in the US, we have a considerably different culture with respect to drugs and advertising than you do in India. And now the advertisers advertise drugs on TV. They advertise all sorts of drugs, and they advertise anti-VEGF drugs. And so the newer drugs, the brolucizumab and particularly faricimab, were being advertised on TV. And so she came to me and said, I've seen these new drugs. I want to switch. And I said, well, they're good drugs. Okay, let's switch and let's see what happens. So I said, in fact, let's really play a game here, and we'll switch your right eye to brolucizumab, and we'll switch your left eye to faricimab, and we'll see what happens. And this result surprised me. So you can see at the top is where she was after her aflibercept. And now she goes through 3 injections, brolucizumab in the right eye, faricimab in the left eye, and the morphology gets worse and the vision gets worse. And I was surprised. I did not expect this. But clearly at this point, we've gone the wrong direction after 3 injections. So what do? Well, we switch back because I don't like the direction this is going. So I switched her back. And indeed, I got her back to where she was. 2030, the morphology was a little different. And 2050, again, a little bit of fluid. So when you switch, be prepared to switch back. I liken this to a very high stakes poker game where you make a very high bet. You're going to win a lot or you're going to lose a lot, but you have to be prepared for either eventuality when you switch because the averages with switching are not very good. On average, you don't improve very much. You might improve a lot, and in which case you found a winner. You might get a horrible result, in which case you need to quickly switch back because we know that there's significant variance in standard deviation. So think of this as a probability game. Switching is all about probability. You might get the winner, you might get the loser. On average, you're not going to change much. It doesn't mean you shouldn't switch. It just means prepared for both eventualities. This was another patient, diabetic, with diabetic macular edema, and I treated her for several years. She's even had a little bit of modified grade. You can see at the top, 2025 on this side, not bad. She's on aflibercept 2 milligrams. I'm treating her every 4 to 6 weeks. And look what happens over 3.5 years. We get her down to the bottom and she's got significantly thicker macula. Her visual acuity has dropped to 20/40. I'm not happy with the direction this is going. And at this point, faricimab became available. So I switched her to faricimab. And here's the result of faricimab injections. And you can, probably the best way to do it is to look at the topographic map on the top of the thickness. You got 1, 2, 3 faricimab, and her visual acuity is now 20/70. You can see by the thickness, she's clearly gotten worse. So once again, somebody who didn't win, if you will, the switching lottery, she's gotten worse. And so what we're going to do is we're going to have to switch, and we'll go back to that later as to what happened. So when I look at this, I reminded of a conversation I had with Peter Kaiser from the Cleveland Clinic, who were sitting next to each other at a meeting. And this was back in 2023. They had looked at the data from Cleveland Clinic on patients who were switched primarily from aflibercept 2 milligrams to faricimab. And he said, what we found, a third of the patients got better. A third of the patients got the same. A third of the patients got worse. And of those that got worse, they got better again when we switched them back. So again, it speaks to this. On average, switching doesn't make a difference. But the reality is you might get this or you might get this. And you have to be prepared for both eventualities. If you get the winner, you continue going. If you get the loser, switch back because you may get back to where you were. Just keep in mind that switching is an active process. This is called the Truckee study, and this was a post-approval study of experience with faricimab in the real world. And what they found was that in this, they included 80% of the patients or so had previous therapy with aflibercept and were switched. And on average, they improved visual acuity by about 1 to 2 letters after the switching. Again, modest changes. The one thing I don't like about studies like this, and this is not just drug dependent, this is any switching study, is that I hate them because they're not controlled trials. You'd have no idea how often they've been treated ahead of time, what the last interval is between their previous injection and starting the trial, and then going forward, they have non-randomized. So you don't know what would have happened had you continued your current drug. And so switching trials, to me, we always look at with a lot of suspicion. To me, there are only 2 good switching trials in all of ophthalmology, and neither of them was macular degeneration. One of them was DRCRnet protocol AC, which was a switching trial in diabetic macular edema, and it showed that patients who had a poor response to bevacizumab when switched to aflibercept actually caught back up to where aflibercept initially treated patients ended up, and it was a really good response anywhere after 3 months. So AC is for diabetes, and then SCORE2, which was for vein occlusions. And in SCORE2, patients were randomized at baseline with vein occlusions and macular edema to receive bevacizumab or aflibercept 2 milligrams. And after 6 months, the patients who were poor responders in bevacizumab were switched to aflibercept. And on average, they improved 9.9 letters after the switch. The aflibercept patients were switched to Ozurdex, and they improved 2 letters over the course of 1 year. So we do know that patients from bevacizumab can benefit from a switch. From aflibercept, those patients got drier, but on the other hand, they didn't improve their visual acuity very much when switched to steroids. I love steroids in the sense, let me rephrase that. I have a love-hate relationship with steroids because I love the fact that they dry. I hate the fact that they cause glaucoma. And when you look at the results in the literature, and I've been through 2 of these studies that I published, where we had anti-VEGF monotherapy with an incomplete response. We then randomized patients to continue monotherapy versus combination therapy of anti-VEGF plus Ozurdex. And what we found after 6 more months was the visual acuity results at the end were exactly the same. It didn't make a difference. The patients who had Ozurdex dried better. They had a dry macula, but they didn't improve the visual acuity. And so I think that when we talk about diabetic macular edema and vein occlusions, there's a lot more to visual acuity improvement than just drying, because I think that there's a survival effect of giving the drug that helps the photoreceptors function and probably helps the inner retina that is independent of drying. So not to say we shouldn't want to dry, but drying is not necessarily the only endpoint to consider in these patients. With switching, I'm going to show you this study, and I want you to look at the title on the top. This is from JAMA Ophthalmology, and it was called Evaluating Effects of Switching Anti-VEGF Drugs for Age-Related Maculation and Diabetic Macular Edema. And this is data from 2 studies, from DRCRNet Protocol I and from CAT. Now, what doesn't make sense about that title from those 2 trials? Patients were never switched. There was no switching done in those trials. But what the authors did, and this is Rick Ferris and Dan Martin, these are really smart guys, is they said, let's evaluate our patients who, over the course of 3 or 6 months, because people throw out numbers of 3, switch after 3 months or switch after 6 months. Those are sort of common numbers people consider for switching. Let's evaluate the poor responders at 3 and 6 months, and then determine what happened in these trials going forward from there. Now, we didn't switch them. What happened? And what we found was the visual acuity with the vascular macular degeneration and DME improved in all these patients. So it's not that they benefited from switching because they weren't, it's that they were late responders. And some of the switching that we may see in real life isn't a matter of switching drugs, it's just a matter of continued therapy because they're late responders. It's not that they're non-responders. So this is a very important trial to suggest that be careful about switching too early. Certainly after 3 months of worsening vision, I'm going to switch. But I'm going to go at least 6 months before giving up on an initial drug because sometimes these are just late responders that need further treatment. And DRCRNet Protocol T showed that between 3 months and 6 months with continued therapy, significant percentages of patients had improved vision and drying with each subsequent injection. And so giving up on patients at 3 months is not necessarily the right response in many of these patients. So a lot has been made about drug characteristics and particularly binding targets. VEGF, aflibercept on the left binds, of course, VEGF-A very well and very strongly, but it also binds the placental growth factor as well as VEGF-B and galectin. Faricimab, of course, is the bispecific of VEGF and Ang-2 binding. So does Ang-2 make a difference? Now, what's interesting about Ang-2 is that Ang-2 was discovered by the scientists at Regeneron. So Regeneron found Ang-2 and actually looked at that in phase 2 trials. They developed an antibody to Ang-2, which is called nesvacumab. And here are the results of the Regeneron phase 2 trials of aflibercept and nesvacumab compared to aflibercept monotherapy. And what they found for AMD on the top and DME on the bottom is combination therapy of Ang-2 binding and VEGF binding didn't seem to make much difference. And so Regeneron decided, we don't think Ang-2 is worth pursuing. We're not going to go into phase 3. Now, Genentech did a little bit different because they created a single drug. And a single drug gives them flexibility. They can go for superiority, but a single drug, they can also go for durability and still get FDA approval, where you can't when you add a second drug. And so they initially looked for superiority, couldn't find it. I showed you the Avenue trials. And so they ended up with Tenaya and Lucerne, Yosemite and Rhine for macular degeneration and diabetic macular edema. And of course, they found that the drug behaves very similarly to aflibercept 2 milligrams. And what they did do was they were able to extend some of their patients up to 16 weeks over the course of the trial. So and it has a really good durability signal. Now, does Ang2 contribute to that? Because there are more differences between faricimab and aflibercept than just Ang2. Faricimab is a larger molecule. It stays in the eye longer because it has a longer half-life. It has a higher molar dose, so it has a greater concentration of drug at any given moment than you do with faricimab, with aflibercept. And so we can't separate out the Ang2 from those other factors that may contribute to the durability of the drug. When you look at the FDA, when they approved faricimab because they found it works well, and we have great signals, they said at the bottom that the contribution of Ang2 inhibition has yet to be established. Nevertheless, they approved the drug because it works. On that note, back in 2023, I was at a meeting in San Francisco, and I spoke with one of the Genentech scientists at a break. And he looked at me and he smiled. He said, "We still have no idea if Ang2 inhibition works." And so even they don't know if it works, but they created the molecule, and hence we have the molecule. So when you think about Ang2 inhibition, it's like, well, okay, we have a molecule that does have an Ang2 binding arm, but we don't know that that contributes to the molecule. The molecule itself has other attributes that work well. And so we don't know that that actually makes a difference. We also know that there's a lot of data to show that the Ang2 levels go in conjunction with VEGF. As VEGF rises, Ang2 rises. As VEGF falls, Ang2 falls. Whether you bind Ang2 or not, Ang2 levels parallel VEGF levels. And probably VEGF is a contributor to Ang2 synthesis. Why would that be the case? Well, it's a multiplication pathway, right? If you have inflammation and ischemia sufficient to the point of causing VEGF upregulation, you'd like other pathways to contribute and give you an amplified effect on the tissues, because that's the body's way of responding to injury. And so the multiple pathways that work and amplify the results. This goes back to the fact that Regeneron was actually the original discoverers of Ang2, and George Yancopoulos was the head scientific officer, and he's credited with actually describing Ang2. So once again, it's this VEGF drive that probably determines Ang2 levels. So does that mean that you shouldn't bind Ang2? Well, let's go back to the Avenue trial. This was the phase 2 trial for faricimab compared to ranibizumab. And Genentech was hoping that faricimab would be superior, give you better visual acuity results. That didn't happen. One of the things that they did in a group in most of the patients was they determined Ang2 concentrations at baseline as well as 28 days later. And they did that for each of the cohorts, all of the faricimab cohorts, but also the ranibizumab cohort, which has no Ang2 binding. And what they found was Ang2 levels with treatment fell dramatically from baseline to week 4. But when you look at the individual cohorts, you can see that all of the faricimab cohorts, which are the 4 on the right, actually did quite well. The Ang2 levels fell dramatically. But look on the left, that's ranibizumab. The gray is the Ang2 concentration at baseline. The little purple way on the bottom of the back, that's the Ang2 concentration after 28 days. And you can see that giving ranibizumab by itself caused a dramatic fall in Ang2, speaking to the fact that Ang2 seems to correlate more with VEGF concentration than it does with any binding effect of Ang2 itself. And so that shows that if you can lower the the VEGF concentrations, you lower the Ang2 concentrations. And we see that in animal models, where aflibercept in an animal model is the most potent suppressor of Ang2 concentrations of any of the anti-VEGF drugs, even though it's not an Ang2 binder. And so we go on to biosimilars and shift gears here. And then, I'm sort of preaching to the experts here because here in this room, you have probably more experience with biosimilars than anybody else in the world, studying with Razumab. And now I understand there's one of the aflibercept biosimilars available here. We have one in the United States, that's Pavblu by Amgen. And it's being used somewhat. What's interesting in the United States, and I think you people will find this very almost funny, is that in the United States, the cost of the aflibercept biosimilar is greater than the cost of aflibercept. It's actually higher. And the same thing for the Lucentis biosimilars. The Lucentis biosimilars are now higher than the cost of Lucentis. Now, they've driven the cost down a little, but the biosimilars cost more. So it's a very interesting concept of, do biosimilars drive down the drug prices or the drug costs in anti-VEGF therapy? In the United States, the answer is no, it doesn't. There's only been a fairly modest uptake of the biosimilars in the US. Most people have stuck with the originator molecules. And of course, one of the things we do is we look at India and we look at your experience of Razumab being taken off the market for a while because of inflammation. And understand there was a batch of the new aflibercept biosimilar that also had to be recalled because of inflammatory problems. The reality is all drugs cause inflammation, but all drugs don't cause inflammation at equal frequencies. And when you look at the inflammation issues, aflibercept has been shown over the course of the years to have the lowest incidence of inflammation. And the reason for that is it's not an antibody, but it looks like an antibody, but it's an entirely human fusion protein. It's not derived from an animal, it's totally derived from human. So as a result, has lower immunogenicity, not zero, but lower than any of the other antibody-based drugs. So the problem with biologics is it's very difficult to create a biologic that's exactly the same as the originator molecule. Generics are easy because they're small molecules, 300 or 400 Daltons. These are more than 100 times as large. And though they can get the basic protein sequences or the primary structure the same, trying to get the folding and the binding together of the different fragments into quaternary structure is very difficult in biologics. Furthermore, you have issues such as glycosylation. And glycosylation has glucose moieties bound to the molecule at various places that contributes to immunogenicity and durability. And there's no roadmap for those. So the manufacturers of the biologics can't replicate that, and they can't determine exactly where they are. So you actually have, as a biologic, a different molecule than the original. It's similar because it has the same protein sequences, but it's not the same. And so it may contribute to changes in durability, efficacy, and immunogenicity because of things like that, and the excipients that are in the fluid itself, because excipients, the different stabilizing agents in the soluble solution, is also going to contribute to not only durability, but also to safety. And so as a result, pharmacovigilance, or evaluating the incidence of adverse effects after the fact, is a critical feature for biosimilars. You've seen that in India, both with respect to ranibizumab as well as aflibercept biosimilars, is that we always have to be looking for incidence after the fact. We learned a strong lesson in the United States from brolucizumab, where there was a signal in the phase 3 Hawk and Harrier trials that the inflammation incidence was higher with brolucizumab, but nobody paid too much attention to it until shortly after approval, when we had incidences of occlusive vasculitis. And so in the United States, the use of brolucizumab is very low because of that risk of about 1 in 700 of inflammation, 30% of whom get irreversible vision loss because of occlusive vasculitis, which is not treatable. I've had people in Europe say, I use brolucizumab, and when I get inflammation, I treat it aggressively with steroids, and they do fine. Well, 70% of those are not occlusive vasculitis. They're minor inflammation or minor vitritis. It's that 30% that doesn't respond to therapy. Because, I'm a specialist here, and I know you people have a lot more experience with uveitis than I do. When you get occlusive vasculitis from uveitis, what are the chances of opening those blood vessels again with therapy? And I think the answer is probably 0. Once it's closed, they're closed, and you can't get those back. Same thing with occlusive vasculitis related to brolucizumab or any of the other intravitreal drugs. And so you have to be careful with the biosimilars. Do watch, be very attentive to what's going on, look for inflammation, and be sure to report those to the appropriate agencies because we do need to have a repository of cases. How do we make these drugs better? So when we look at simple mathematical modeling maps, your goal is to keep the concentration of drug, which is the solid line, above the hatched line, which is the concentration needed to effectively suppress VEGF. Once you get below the line, then you're going to get disease recurrence. And so one of the ways to make a drug that lasts longer is to make a higher binding affinity. Higher binding affinity means the drug becomes active at a lower concentration. So it's going to last longer because you can do it with a lower concentration over time. The trouble is that we have no drug that has a higher binding affinity than aflibercept. And that's neither experimental nor clinical. And so we're probably not going to have any avenue to make a longer durability drug by making a higher binding effect drug. So the drug developers recognize this and they've all pivoted. And what have they concentrated on? Well, mostly they've concentrated on higher molar dose. Bevacizumab is the perfect example of that. Its molar dose is 11 to 13 times that of aflibercept. Faricimab is 2 to 2.5 times. And now, of course, we have aflibercept 8 milligrams, which is quadruple the dose of 2 milligrams. So they've all gone to higher molar doses to get more drug in the eye to delay the decrease in concentration to where it falls below the threshold line. And in doing so, you push the timeline to the right and increase the durability in that way. And the model here just sort of illustrates the higher dose on top, the lower dose on the bottom. Over time, the concentrations obviously fall, but at any given time point, you still have a concentration of a higher dose drug relative to lower dose drug, hence the delta or the improvement in time. Regeneron and Bayer have loved this model of shifting the curve. And we tend to find there's sort of there are two peaks with respect to treatment duration. One is the group on the left who require injections frequently, that actually do quite well. And generally, most of the time we're looking at 10 and 12 weeks. Can we change the curve to make people last longer between injections? One of the things that the drugs do, and 8 milligrams, we'll see this when you get access to this and see some of the data, is that we've decreased the number of patients who require very frequent treatment. Now, the 8 milligram is not going to take a patient who's stuck on 4 weeks and to put him into 20, but they will make them from 4 to 6. They'll make them from 8 to 12. And in my experience, 8 milligrams generally increases the durability of a patient who's treated successfully, but it increases the durability by about 50%. So that's about where you sit with 8 milligrams compared to the 2 milligrams. The other thing we do is take those patients that are doing well. They've been happy on 10 weeks, but maybe they'd like to go to 15 weeks. And so by giving them a new drug that lasts longer, we can switch that part of the curve as well and get them out further. And so that's what 8 milligrams is proposing to do, is increase the durability. The other thing, especially as you adopt this drug and start using it and look at switching patients, is look at those patients that are having a hard time drying and getting beyond 4 weeks, because there's a significant percentage of those that we can get dry and we can get extended a little bit further because it has a higher drug concentration in the tissue than aflibercept 2 milligrams, at least 4 times. And that shifts the equilibrium curve, so you drop the level of unbound VEGF. And it's unbound VEGF that's the culprit, and that's what 8 milligrams does. It drops the level by at least a factor of 4 compared to what you have with 2 milligrams. And finally, global evidence. When you look at what people from the ASRS in the US do in their yearly polls, what's the preferred first-line therapy if no payer access? International and domestic, aflibercept 2 milligrams remains a drug of choice. And if, particularly in those patients of 20/50 or worse with diabetic macular edema, the protocol T patients, again, aflibercept is far and away the drug of choice because it has such good data to show really superior effect over the other available drugs at that time. And so aflibercept has been the global leader for on-drug use for the treatment of angiogenic conditions, and it has excellent efficacy, durability, and safety. And when we evaluate drugs going forward, those are the 3 big words: How effective is it? Is it effective as comparable therapy? Does it last longer? And is it at least as safe? And those are the criteria that we should always keep in mind when we're choosing drugs. So thank you very much.
Thank you.
Thank you.
Lord, I apologize for having come a little late. And a very interesting talk. I think you touched on multiple things. One is, the drug, the switching, and durability, and the biosimilars. So, how do you go about the panel discussion? So I thought I'll just start with the first question. You spoke about switching and coming back. Actually, I myself wanted to ask you that particular question, but then you handled it. But then we switch for two reasons. One is when you get a poor response, and the second is you get a good response, but then you end up, say, injecting every 8 weeks.
Yes.
You're not able to extend further. So that's when you want to try another drug, thinking to reduce the injection burden. So there are two. So the switching and going back. What sort of patient? Was it patients who were because of a poor response, or patients who, had a good response, but or it's a mix? Is there any data on that?
Yeah, the patients who, let's say they're treated, they haven't had a good visual acuity response. The maculas are reasonably dry. I find that switching those patients generally doesn't work very well. Because you've got a fairly dry macula, and switching to a different drug is probably not going to regenerate photoreceptors or help the RPE. But it's those patients that have a poor visual response or inadequate and persistent fluid that you can't get rid of. Those are the patients that I think we would all target for switching, especially if we're treating them every 4 weeks and we never get them dry. Those are patients who are absolutely perfect. Now, those are the patients who you've got to probably go ahead and do a regimen for those patients. And once again, I said at the beginning, I don't believe in loading regimens per se, but those are the patients who one injection is probably not going to drive them. They need 2 or 3 or more before they get dry or improved to the point where they can be extended. And they can be extended modestly. And sometimes with improved visual acuity as well in those patients who are very specifically at 4 weeks or very short intervals that don't have a good response. So that's the switching patients of the inadequate responders. The other group that you've pointed out very nicely are the ones who respond well, but have an interval that seems to be locked in. And, let's say 8 or 10 weeks for argument's sake. And, can they be extended further by switching to a longer durability agent? The answer is generally yes. They can be switched further. Now, I approach those patients differently because I'll give an injection and then I'll usually see them back a week or 2 longer than the previous interval because I know they've done well. Especially if I'm switching from 2 milligrams to 8 milligrams, then I know that if the 2 milligrams lasted 8 weeks, then there's no point in bringing them back at 8 weeks after 8 milligrams. I'm bringing them back at 9 or 10 because I know they already passed the 8-week mark based on the drug. And so now I go to 9 or 10. If that works well, I'll go to 12 or 13 and I'll extend based on that. But in those patients, because they've already got a good anatomic response, I don't feel that loading really comes into the conversation. So loading yes on poor responders, loading no on extenders who responded well.
Since we are on switching, you showed a couple of cases where you switched from aflibercept to brolucizumab and they worsened. So similarly, when you switched to faricimab also, some cases worsened. Retrospectively, could you find any marker which case could worsen and which case could improve?
Yeah, no. I wish I had good markers to talk about. We find standard markers, and looked at all the fluid compartments and looked at hyperreflective dots and drill for the diabetic patients. But the reality is we've not found anything that is predictable or valuable in a statistical way. So that's why I follow these patients carefully, because I don't feel I have the ability to really predict who's going to be responding well and who's going to respond poorly to those drugs, especially as we think about, drugs that are fairly similar. similar modes of action. Because all of these drugs, regardless of which drug we have, their primary mode of action is anti-VEGF. And I don't know if there are any markers to tell us, does Ang2 binding make a difference either positively or negatively in terms of response? I don't think we have biomarkers to tell us that, so. No.
So especially treated cases of wet AMD, mostly pulmonary vasculopathy. If after the loading dose, sometimes we see that stable SRF, subretinal fluid. You don't tolerate the internal fluid. When do you decide, besides vision as a marker, how would you decide to treat that case or whether you would like to tolerate that fluid?
Yeah, so what I'll do is I'm going to try to get rid of the intraretinal fluid as much as I can. And, you know, probably in my own mind, I have probably 6 months of aggressive treatment before I'm going to give up on that. Because as we know, there's some patients who just, you never get rid of subretinal fluid, intraretinal fluid, and some intraretinal fluid is not true leaking, but sometimes degeneration. And that's been described as well. And so those patients, you can't get rid of those intraretinal cystoid spaces. I'll give myself about 6 months before I kind of give up. In those cases, as long as otherwise it seems to be improved vision and fairly stable, slowly extend. For subretinal fluid, I'm going to go quicker. For subretinal fluid, it's 3 or 4 months of improvement and instability at some level. I don't measure subretinal fluid thickness, but in my mind, I'm thinking probably less than 100 microns. And if I get them to the point where they have improved visual acuity and stable after 3 or 4 injections, and they're less than 100, then I'll start to extend those patients. The RPE detachments, as long as it's not getting worse, or as long as it's not over in literature, the magic number is about 390 microns is very high risk of RPE tear, then I'll accept those. With regard to polyps, we now bring in the question of not only are you looking for visual acuity improvements and drying, but now you're looking at polyps. If you go back and you do your ICG angiograms and say, do I have a persistent polyp, an active polyp, or a polyp that's completely regressed? And, you know, of course, if you've got a dry retina, then you probably don't have an active polyp, but you may have some that persist. The people who are treating this, and I look to the people in the Far East on the Pacific Rim as the expert on this, they're moving away from PDT. And so what that means is they're tolerating persistent polyps as long as they're inactive, they're controlling the fluid. And so getting rid of polyps is not necessarily the end game in PCV as long as you've made the polyps inactive. And so they're tolerating the polyps. And when you look at Pulsar trial, so Pulsar, of course, was worldwide, and it was neovascular AMD, and of course it had a subset. And the subset had about 240 patients that had PCV. It was documented by angiography. And what they found in the trial is that there was a slightly higher percentage of patients receiving 8 milligrams compared to 2 milligrams that had persistent polyps. Now, you can kind of think of, why is that? You know, if this is a better drug, why do we have more persistent polyps? Well, the reason for that was you've had patients who are treated every 12 and 16 weeks rather than every 8 weeks, which was the 2 milligram drug. So you really extended it. But what they ended up finding was, even though they had persistent polyps, not active, but persistent, that it did not affect the durability of the drug, to shorten it, and it didn't increase the risk of bleeding or compromise visual acuity. And so there's more of this belief you can tolerate a polyp, but on the other hand, you have to figure out yourself, if you have a persistent, though inactive polyp, are you going to stop therapy? And I think most of us would say probably not. We're probably going to get to the point where we're going to continue to treat those because we're so worried about reactivation and hemorrhage. So we would treat those. But the good news is the 8 milligrams, for example, is able to treat better by keeping the disease under control, even though polyps were persistent but inactive.
Here we have 2 entities, mainly neovascular AMD and DME. Of course, polyps are there. But between neovascular AMD and DME, would your tolerance of fluid level be the same or different? How much fluid would you ignore? How much fluid would you
Yeah.
treat a switch?
So obviously the fluid we're talking about is very different because, in DME, of course, we get subretinal fluid, but that's not really the primary marker of disease as it is with AMD, where subretinal fluid is so very common because of the location of the leaking. So in AMD, I'll tolerate subretinal fluid, but I want to try to get rid of intraretinal fluid. DME, it's a very different story. And the best data comes out of Protocol T, where a patients with persistent intraretinal fluid after 6 months, their visual acuity results were almost exactly the same as those who had completely dry intraretina's. And so it suggests that the presence of intraretinal fluid in DME after treatment is not really a sign of poor visual acuity results. And so that intraretinal fluid can be tolerated much more in DME. And I will extend if I have stable, persistent fluid with stable vision. In DME, I'll start extending them. I really don't like stopping them because I think there's enough active disease that if you stop, the fluid's going to get worse and you're going to go back again. But I will extend. So I'll tolerate intraretinal fluid in DME. I'm very hesitant to tolerate intraretinal fluid in AMD.
Professor Stewart, on the same lines as switching, when we showed the pictures of aflibercept and then you start faricimab, there's a worsening. So one of the reasons what you said was the ranibizumab arm of the. So when you actually look at it, the contribution of ranibizumab, it exactly is around 2 milligrams of the molecule. So the earlier studies have also shown that 0.5 and 2, you had again mentioned that
Yes.
it was not as good as 0.5. So probably maybe that's one reason that the worsening has happened. And
Yeah. It may well be one of the reasons why faricimab is a pretty good drying agent because it's like a superdose of ranibizumab. And it's funny because when Genentech did their trial, the Harbor trial, which I alluded to, and they found that 2 milligrams was not superior to 0.5 milligrams, they did it entirely in AMD patients. But there's another batch of data from the literature that shows that 2 milligrams, when it was available, was actually a pretty good rescue therapy for certain patients. So once again, you get into that switching component where you might get really good results in patients that were hard to treat. So I think the way to think of ranibizumab, one of the ways to think of it is it's a super dose of ranibizumab with a longer intravitreal half-life. And by the way, it also has this Ang2 arm that we're not sure about. That's why I think of it.
And another one point is that even though we call it as a dual antibody, it doesn't bind to both at the same time. Simultaneous binding is not there. So one is taken up, the other one is not going to act. So that way, probably, I don't know whether the Ang2 is going to decrease the amount of VEGF suppression in the long run. And when the concentration is actually exponentially decaying, at that time, probably the Ang2 would be something which is going to interfere, I guess. I don't know about that.
No, I mean, if the Ang2 levels correlate with VEGF levels, then it's probably the VEGF that does more. There's other data that says that when you look at binding affinity, and then you look at the Tie receptor, which is, of course, what you're trying to prevent from happening. You don't want the Ang2 to bind to the Tie receptor. You want to bind it when it's in solution. And the way you do that is to get a stronger drug than the receptor, because they're fighting each other. Now, whoever has a stronger binding effect wins. And comparative data suggests that the Tie2 receptor has a stronger binding affinity than does the Ang2 arm of faricimab. So once again, an argument that says maybe that's not the case. Maybe it's the Ang2 is not doing the binding. Maybe it's the VEGF regulation.
Thank you, Dr. Stewart. I was just shifting gears from neovascular AMD and DME, now slightly over to PCV. If you look at PCV, and having said that, there was a slide which you had mentioned that Ang2 probably doesn't work, and or they don't have an explanation what role it has per se. Then how do we explain that when ranibizumab per se failed as a monotherapy in cases of PCV? How do we explain the Salvine trial in which we have seen a 61% kind of reduction or a polyp closure in PCV with faricimab alone?
Yeah. So the question. So why does faricimab work better than ranibizumab? If we take a step backwards, we know from the previous trials that ranibizumab as a monotherapy does not work as well as ranibizumab combination therapy with PT. So ranibizumab is not our best choice. Planet trials show that aflibercept does work pretty well. And aflibercept monotherapy for PCV versus aflibercept in combination with PDT was pretty much exactly the same. And only about 15% of the aflibercept monotherapy arm required PDT, so a very small percentage. So therapy can work, but it is drug specific. And faricimab has shown itself to be a good drug for PCV. Now, very much as stated, it's sort of a superdose. It's a superdose of ranibizumab, so it has 4 times the concentration in solution, and it has a longer half-life. So I would argue that if you put in 4 times the ranibizumab dose and made it last longer, you might get what you see with faricimab. Anybody from the audience?
Yes. Yeah, PCV will leave it from the, since
Okay.
Dr. Ramesh is talking on that. Okay. Other than the visual acuity and the fluid, would you consider any other markers, the hard exudates or the disappearance of microaneurysms for switching?
Yeah, I usually don't. I tend to get that good. I tend to look at visual acuity because ultimately, Carmen Puliafito from the US made a great statement one time and he said, treat the patient, don't treat the OCT. And so if you get a good visual acuity result and you look at the basics, which are pretty much your fluid compartments, and you get an acceptable fluid change and you get good visual acuity improvement, I tend not to go any further than that in terms of looking at things like microaneurysms, et cetera. Now, having said that, I'm not in line with other people because there are a lot of people who will say if you get an inadequate response in a patient with DME, then should you consider laser photocoagulation? And many of the very smart retina people who do trials, what do they do as a rescue therapy? It tends to be laser. And laser either as focal therapy to microaneurysms, a modified grid. And so there are a lot of people who will do that. It does tend to drive the retina better. And so angiograms and looking at aneurysms and patterns of leaking does make sense if you're going to go and do laser. But I'm not convinced that in most patients with center-involving DME, there's an incomplete response to anti-VEGF therapy. I'm not convinced laser makes them better. Now, why do I say that? So does it make them a little drier? Yes. Does it improve the vision? So we'll go back and we'll look at, do we have any trials that compare anti-VEGF therapy alone to anti-VEGF plus laser? And there are 2 really good trials. One was Protocol I, and the other was Restore. Restore was the ranibizumab trial for DME done in the Eastern Hemisphere for approval. And so in both of the trials, the visual acuity improvements at everything past 1 year favored the anti-VEGF monotherapy group. And the laser group, which was laser optional, always had visual acuity a little bit less than the monotherapy group. So I look at that and I go, I don't see any data to say that supplementing an inadequate DME response with focal or grid laser gives you better vision. In fact, maybe it actually suppresses vision very slightly. That's the first thing. The second argument that people will make is if you do the laser, then you decrease the number of needed injections because you end up with a slightly drier retina. And that is true, but it's not as high an effect as we'd like it to be. And if you look at Protocol I, and they followed patients through course to 5 years, and how many lasers did they do in the optional arms versus how many injections. And the trade-off was for every time you did a laser, you needed 1 fewer injection. So it's not a big trade-off. And so for those 2 reasons, for center-involving DME, I'm fairly reluctant to do laser. For center-threatening DME, it's a great tool, and I use it all the time. to try to decrease the edema and prevent center involvement. But for center involving, I'm not a big proponent, but I know that a lot of people disagree with me on that.
There's a question from Dr. Manoj at Trivandrum. This talk is being named to Trivandrum. Do you consider the sub-RP fluid as a criteria in line with the IRF also for treatment?
No. So the sub-RPE fluid, I don't look at that as being a good. Now, if you have a very large RPE detachment, you're at high risk if you do nothing. And so I think at that point you swallow deeply and you say, whichever road I go down, I'm at risk, but I would like to try to flatten if I can, and I'll go to a higher potency agent to try to flatten it. So I will do that.
So in a few of your cases, we saw that you were switching after 3 to 6 initial injections. And you were labeling them on the basis of the responses, so good or bad, or even a partial response. Now, when you switch a patient to another drug, what is the expectation? How many injections do you wait to say that, okay, this second drug is not working and I have to go back to aflibercept? And do you categorize the response as the same way as we were doing 75% reduction and less than 5%?
So if I'm switching, then I'm really looking for small changes. And because switching eyes that I would switch are generally difficult to treat eyes. And if I can get any sort of positivity with respect to fluid and or vision, especially vision, then I'll look at that as a plus and I'll keep going with the therapy. If no difference. Suppose I've made a switch and I've done 6 injections, I've made no difference. Then I'm lazy and I'll keep going with that switch drug. I think you can make an argument for going either way, but if you haven't made things worse, then I think either of those 2 drugs is probably acceptable. I tend to continue the drug I've switched to, but either would be an appropriate choice. But when they get worse, especially if the vision gets worse, those are the ones I switch back. And if I'm comfortable, but I'm confident that the vision worsening is real, and it's not just a matter of the technician and the patient didn't get along that day, then I'll do it at that point. And that could be as few as 2 injections. You saw that one patient of 3 injections. So when I'm confident it's a real change, I'll do it as early as 2 and 3 injections.
Another question on intraocular inflammation is that you have the experience of using 8 milligram of aflibercept. It's basically 4 times the dose of what we are using currently. Do you find more intraocular inflammation incidence with 8 milligram compared to the 2 mg of aflibercept?
So good question, because pharmacologically, when you look at things like adverse events, or toxicity is a better way of pharmacologists to determine it, and you look at efficacy, then efficacy is determined by the trough concentration of the drug, and toxicity is determined by the peak concentration. And of course, 4 times, you would expect more toxicity. Now, do we see that with 8 milligrams? And the short answer is I've not seen that. And I'll go back to a couple of things. One is we look at pulsar, and we look at, well, we go from pulsar to photon, and you know, we even have the quasars data that we've seen, is that the incidence of inflammation is pretty much exactly the same with 8 milligrams as with 2 milligrams. So it has not shown us an increased incidence of doing that. You know, is there a reason for that? Well, I go back to what I said before, and this is an all-human molecule, and there may be something different about an all-human molecule versus an antibody, animal-based antibody molecule that's humanized. So I've not seen that in the literature. Although there are cases in literature with inflammation, I've not seen that as being a problem different from 2 milligrams. In my practice, I've had one patient who's had inflammation. And this is a case where in hindsight, the answer is obvious. Why? Because she had come to me from up north, and she was on bevacizumab at that time. After a couple of injections, I couldn't get her dry. I switched her to aflibercept 8 milligrams, and she had an inflammatory response. What was interesting about the response was her vision was 20/40 with subretinal intraretinal fluid when I injected her. She came back 5 days later, and again, I wasn't there, but one of my colleagues saw her, and he described it as 4+ vitreous cells. Now, those of you who are uveitis specialists know 4+ vitreous cells mean you can't see the retina. But the visual acuity went from 20/30, was at about 20/40 at that point. So we know it wasn't 4+ vitreous cells, but it was impressive vitritis. So treating the patient topically. Patient came back another 5 days later, so 10 days after my injection, and saw me. Most of the vitritis was gone, the vision was 20/30, and the retina was completely dry. So it's like the strength of the drug far exceeded the adverse effects of the inflammation on the retina because the eye dried completely. Now, the rest of the story, when I talked to her, was that, oh yes, 5 years ago when she was up north, she got aflibercept 2 milligrams and had an inflammatory response. So we think it's drug-related as opposed to dose-related. And that's the only one I've seen. So in well over 1,000 injections, I've not seen any other inflammatory issues besides that one. And, you know, if we go to the rest of the story of, you know, the other thing that we think about is increased inflammation, increased pressure-related problems. I've only had one injection that I've done a paracentesis. And that patient, after the paracentesis, because she couldn't dry her AMD with previous drugs, including 2 milligrams, a month later, she was completely dry. So that's the only one I've had of the pressure issues, and the only one I've had of inflammation.
You talked extensively about fluid, but does OCT angiography-based biomarkers guide your treatment?
I tend not to use the OCTA probably as much as I should. And so if I see an increasing, my own belief is if you have an increasing OCTA, but you have good visual acuity, you have no fluid, and you've had a good response to therapy, I don't know that I would chase the OCTA. And we know that there are many patients who have silent OCTA, inactive OCTA that never need treatment. So I look at that as more of a compensatory mechanism. And in the absence of fluid, so we have some disease control, and in good visual acuity, I tend not to chase the OCTA.
Another thing is about switching. You basically said that, if you are trying a first drug in a treatment naive eye, probably you will wait for 4 or 5 or 6 injections.
Yes.
Before you you decide on the rest.
Yes.
Switching, but you would not take that 6 injections. You would probably look at switching back if for the next
yeah.
2
Oh, yeah.
injections it's not doing well.
Yeah. Yes. I think
In the case of aflibercept, also reducing the PIGF, all the other drugs do not reduce the PIGF.
Right.
So in the short term, in 2 months, there may be a upregulation of PIGF, which is causing the worsening here.
Yeah, so a couple of things in there. One is how long does one wait before switching back? And if I'm seeing a worsening response, I usually wait at least 2 injections. Because with 1 injection, I don't know if I've had reflux of drug out of the eye. I don't know exactly how effective I've given it. My dose may vary. So I usually wait at least 2. But if I'm getting worsening, and not just subjective, but also objective worsening. So the patient says my vision's getting worse. The OCT looks worse, I'll switch back. But other than that, I'll wait for up to 6 injections at least before, considering is this a non-responder after a switch or not. And as I said before, in many of those where I've switched and they've stayed the same, I just continue the same drug, even though both drugs would be appropriate. And the paternal growth factor is a very interesting idea because much like Ang2 is a parallel pathway to VEGF through receptor 2, well, placental growth factor through receptor 1 is a parallel pathway. It does increase neovascularizations. It also is pro-inflammatory, placental growth factor. And so much like Ang2, we don't have a good understanding if low placental growth factor concentrations actually does anything. We know it exists. We know in by itself it's pro-inflammatory. Suppressing placental growth factor by itself and not suppressing VEGF doesn't work. Is it additive? We don't know.
We have a large number of questions from the remote locations, but due to paucity of time, I'll take just one. When do you adopt a PRN schedule in your practice? Is there any role for that?
I'm sorry, what do I adopt what?
PRN schedule, progranulin. Whenever there is fluid, you treat.
I'm sorry, say that one more time. I just, for some reason, I can hear you.
PRN is pro-retinigra. That means whenever there is a fluid, you treat.
Yeah, okay, so
I'll make a treat and explain the definite schedule.
Yeah, so we were talking about a PRN approach to treat and extend. I tend to be in AMD, I'm very strongly PRN, treat and extend based. And the reason I don't like PRN for macular degeneration is every good trial that's compared PRN to standard monthly therapy, the PRN arms always do worse, always. Be that from CAT or Ivan or Harbor. And so I'm not a big fan of PRN for those reasons. And I think what happens is PRN is a strategy that allows the disease to recur, and it recurs again, and it recurs again, and every time it recurs, I think you end up with some degree of permanent damage that adds up over time. I think in diabetes, it's a different story. I think PRN for diabetes is completely reasonable. And because diabetes is a very forgiving disease, it doesn't lead to permanent vision loss over short periods of time. So PRN, I will often do rather than treat and extend. AMD, I always do treat and extend and never PRN. Does that answer?
Thank you. All good things have to come to an end.
Thank you.
I would request Dr. Giridhar to conclude the session.
Thank you.
After this.
Thank you, Michael. It was an excellent talk, and we'll move on to the next talk by Dr. Ramesh. He has been introduced. So he'll be talking on the evolving role of aflibercept in PCV, APDR's insights, and comparison with other anti-VEGF agents.